If you cannot master renal and electrolytes, you cannot pass the NCLEX. Period. Today on MCQs Master 101, we are breaking down 50 high-level renal and electrolyte NCLEX questions designed for serious test takers, not beginners. We're talking acute kidney injury, chronic kidney disease, dialysis emergencies, acid-base interpretation, potassium crashes, sodium disasters, and ICU-level priorities. These are not memory questions. These are clinical judgment questions. You will think like a nurse under pressure. So get your notebook ready. Pause when needed. Challenge yourself before I reveal the answer. Let's treat these questions the professional way. Question 1. A client with acute kidney injury, AKI, secondary to septic shock, has the following laboratory results. K plus 6.4 milliequivalents per liter, creatinine 3.2 milligrams per deciliter, pH 7.28, HCO3 minus 18 milliequivalents per liter. Which prescription should the nurse implement first? A. Administer sodium bicarbonate IV. B. Initiate 0.9% normal saline bolus. C. Administer IV regular insulin with dextrose. D. Prepare for emergent hemodialysis. Answer. C. Administer IV regular insulin with dextrose. Rationale. Potassium 6.4 is life-threatening hyperkalemia. The most immediate threat is cardiac dysrhythmia. IV insulin shifts potassium intracellularly within minutes. Dialysis may be needed, but stabilizing potassium is priority. Question 2. A client with chronic kidney disease stage 5 reports perioral numbness and muscle cramps. Labs show calcium 7.1 milligrams per deciliter, phosphate 6.8 milligrams per deciliter. Which medication does the nurse anticipate? A. Furosemide. B. Calcium acetate. C. Sodium polystyrene sulfonate. D. Magnesium sulfate. Answer. B. Calcium acetate. Rationale. CKD causes hyperphosphatemia, which suppresses calcium levels. Calcium acetate binds phosphate in the gut, lowering phosphate and helping correct hypocalcemia. Question 3. A post-op client develops sudden oliguria 20 milliliters per hour, urine-specific gravity 1.0350, BUN creatinine ratio 25:1. Which condition is most consistent with these findings? A. Intrinsic renal failure. B. Post-renal obstruction. C. Pre-renal azotemia. D. Nephrotic syndrome. Answer. C. Pre-renal azotemia. Rationale. High urine-specific gravity and elevated BUN creatinine ratio, greater than 20:1, indicate dehydration or hypoperfusion, classic pre-renal AKI. Question 4. A client receiving continuous renal replacement therapy, or CRRT, develops hypotension. Which action is priority? A. Increase dialysate flow rate. B. Stop ultrafiltration. C. Administer IV potassium. D. Flush catheter with heparin. Answer. B. Stop ultrafiltration. Rationale. CRRT removes fluid continuously. Hypotension suggests excessive fluid removal. Stop ultrafiltration immediately to prevent hemodynamic collapse. Question 5. A client with metabolic acidosis has ABGs of pH 7.29, PaCO2 30 millimeters per mercury, and HCO3 negative 15 milliequivalents per liter. Which interpretation is correct? A. Respiratory alkalosis. B. Uncompensated metabolic acidosis. C. Partially compensated metabolic acidosis. D. Fully compensated metabolic acidosis. Answer. C. Partially compensated metabolic acidosis. Rationale. Low pH and low HCO3 negative confirm metabolic acidosis. PaCO2 is decreased, respiratory compensation present, but pH is still abnormal, partial compensation. Question 6. A client on hemodialysis suddenly becomes restless, confused, and develops a headache during treatment. What is the most likely cause? A. Hypocalcemia. B. Disequilibrium syndrome. C. Hypernatremia. D. Air embolism. Answer: B. Disequilibrium syndrome. Rationale: rapid removal of urea causes cerebral edema. Early symptoms: headache, confusion, restlessness during dialysis. Question 7. Which ECG finding is expected in severe hyperkalemia? A. U waves. B. Prolonged QT interval. C. Peaked T waves. D. ST depression. Answer: C. Peaked T waves. Rationale: classic early hyperkalemia change is tall peaked T waves, progresses to widened QRS and sine wave. Question 8. A client with SIADH has sodium 118 milliequivalents per liter. The client develops seizures. Which is priority? A. Restrict fluids. B. Administer 3% hypertonic saline. C. Administer furosemide. D. Encourage oral sodium intake. Answer: B. Administer 3% hypertonic saline. Rationale: severe symptomatic hyponatremia requires hypertonic saline to prevent cerebral edema and neurological damage. Question 9. A client with nephrotic syndrome has generalized edema and albumin 1.8 grams per deciliter. Which complication is highest priority? A. Infection. B. Hypertension. C. Hyperkalemia. D. Hypoglycemia. Answer: A. Infection. Rationale: loss of immunoglobulins in urine increases infection risk. Infection is the leading cause of mortality in nephrotic syndrome. Question 10. A client with post-renal AKI due to BPH suddenly produces 400 milliliters per hour after catheter insertion. What is the nurse's priority? A. Clamp catheter. B. Restrict fluids. C. Monitor for hypovolemia. D. Administer potassium supplement. Answer: C. Monitor for hypovolemia. Rationale: post-obstructive diuresis can cause rapid fluid loss leading to hypotension and electrolyte imbalance. Question 11. A client with magnesium levels 6.5 milligrams per deciliter is lethargic with absent deep tendon reflexes. Priority action: A. Administer IV calcium gluconate. B. Start dialysis. C. Administer loop diuretic. D. Restrict fluids. Answer: A. Administer IV calcium gluconate. Rationale: severe hypermagnesemia depresses neuromuscular and cardiac function. Calcium antagonizes magnesium effects immediately. Question 12. A CKD client has potassium 5.8 and is receiving spironolactone. What is priority? A. Continue medication. B. Hold spironolactone. C. Give potassium supplement. D. Encourage bananas. Answer: B. Hold spironolactone. Rationale: potassium-sparing diuretics worsen hyperkalemia. Immediate medication review is required. Question 13. A client has ABGs pH 7.48, PaCO2 32, bicarbonate 24. Interpretation: A. Metabolic alkalosis. B. Respiratory alkalosis. C. Compensated metabolic acidosis. D. Mixed disorder. Answer: B. Respiratory alkalosis. Rationale: high pH and low CO2 indicate respiratory alkalosis. Bicarbonate normal equals uncompensated. Question 14. A dialysis client reports chest pain and dyspnea. Blood leak detector alarm sounds. Priority: A. Reassure client. B. Stop dialysis immediately. C. Increase blood flow. D. Flush system. Answer: B. Stop dialysis immediately. Rationale: possible dialyzer membrane rupture. Immediate discontinuation prevents exsanguination. Question 15. A client with DKA has potassium 5.5 on admission. Which is true? A. Potassium should not be monitored. B. Potassium will likely drop with insulin therapy. C. Potassium supplementation is given immediately. D. Hypercalcemia is unrelated. Answer: B. Potassium will likely drop with insulin therapy. Rationale: insulin shifts potassium intracellularly, risking hypokalemia during DKA treatment. Question 16. A client with tumor lysis syndrome has labs calcium 6.1, phosphate 7.2, calcium 6.9, uric acid 11. Which order should the nurse implement first? A. Administer IV calcium gluconate. B. Initiate allopurinol. C. Administer sodium polystyrene sulfonate. D. Start IV normal saline at 250 milliliters per hour. Answer: D. Start IV normal saline at 250 milliliters per hour. Rationale: in tumor lysis syndrome, early aggressive IV hydration is the cornerstone of management to prevent uric acid nephropathy and worsening AKI. Calcium is indicated if ECG changes are present or potassium is severely elevated with instability. Question 17. A client with CKD develops metabolic acidosis. Which mechanical mechanism is expected? A. Increased respiratory rate. B. Decreased heart rate. C. Increased bicarbonate retention. D. Increased PaCO2. Answer: A. Increased respiratory rate. Rationale: metabolic acidosis triggers respiratory compensation via Kussmaul respirations to blow off CO2.
Question 18. A client with hyponatremia, sodium 122, becomes increasingly confused. Serum osmolality is low. Most likely cause: A. Diabetes insipidus. B. SIADH. C. Hyperglycemia. D. Dehydration. Answer: B. SIADH. Rationale: low sodium plus low serum osmolality plus neurological changes indicates dilutional hyponatremia from SIADH. Question 19. An acute glomerulonephritis client has BP 178-104 and periorbital edema. Priority assessment: A. Lung sounds. B. Urine ketones. C. Blood glucose. D. Abdominal girth. Answer: A. Lung sounds. Rationale: fluid overload can progress to pulmonary edema. Airway and breathing are priority. Question 20. Which lab trend indicates worsening intrinsic AKI? A. BUN over creatinine ratio 22:1. B. Urine sodium less than 20 milliequivalents per liter. C. Fractional excretion of sodium greater than 2%. D. Specific gravity 1.030. Answer: C. Fractional excretion of sodium greater than 2%. Rationale: intrinsic renal damage causes sodium wasting. Fractional excretion of sodium greater than 2% confirms tubular injury. Question 21. A dialysis client becomes hypotensive and nauseated mid-treatment. Best immediate intervention: A. Place in Trendelenburg. B. Decrease blood flow rate. C. Administer IV albumin. D. Stop ultrafiltration and give NS bolus. Answer: D. Stop ultrafiltration and give NS bolus. Rationale: Dialysis-induced hypotension from rapid fluid removal requires volume restoration. Question 22. A client's ABG, pH 7.51, HCO3 32, PaCO2 48. Interpretation. A. Metabolic alkalosis with compensation. B. Respiratory alkalosis. C. Mixed alkalosis. D. Uncompensated metabolic alkalosis. Answer. A. Metabolic alkalosis with compensation. Rationale. High pH and HCO3 indicate metabolic alkalosis. Elevated CO2 shows respiratory compensation. Question 23. A client with hypernatremia, sodium 158, is lethargic. Which solution is appropriate? A. 3% saline. B. D5W. C. 0.9% NS. D. Lactated ringers. Answer. B. D5W. Rationale. Hypernatremia requires free water replacement. D5W provides hypotonic fluid once metabolized. Question 24. A client receiving amphotericin B develops potassium 2.8. Priority intervention. A. Restrict fluids. B. Administer IV potassium. C. Administer sodium bicarbonate. D. Start dialysis. Answer. B. Administer IV potassium. Rationale. Amphotericin causes renal potassium wasting. Severe hypokalemia increases arrhythmia risk. Question 25. A client with ESRS has pruritus and phosphorus 7.5. Best intervention. A. High protein diet. B. Phosphate binders with meals. C. Increase vitamin D intake. D. Restrict potassium. Answer. B. Phosphate binders with meals. Rationale. Hyperphosphatemia causes pruritus and secondary hypocalcemia. Binders reduce absorption.
Question 26. A client with metabolic acidosis has Kussmaul respirations. What does this indicate? A. Respiratory failure. B. Compensation for acidosis. C. Metabolic alkalosis. D. Hypoxia. Answer. B. Compensation for acidosis. Rationale. Deep, rapid breathing eliminates CO2 to buffer acidemia. Question 27. A client with calcium 12.8 milligrams per deciliter reports polyuria and weakness. Priority action. A. Encourage oral fluids. B. Restrict fluids. C. Administer magnesium. D. Give phosphate. Answer. A. Encourage oral fluids. Rationale. Hypercalcemia causes dehydration. Aggressive hydration prevents renal failure. Question 28. Which ECG finding is seen in hypokalemia? A. Peaked T waves. B. U waves. C. Widened QRS. D. Sine wave. Answer. B. U waves. Rationale. Hypokalemia causes U waves and flattened T waves. Question 29. A client post-renal transplant has urine output 15 milliliters per hour. First action. A. Notify surgeon. B. Assess for obstruction. C. Increase IV fluids. D. Administer furosemide. Answer. B. Assess for obstruction. Rationale. Check catheter patency first before escalating. Question 30. A client with CKD has hemoglobin 8 grams per deciliter. Anticipated therapy. A.
iron restriction, B. epoetin alpha, C. platelet transfusion, D. sodium bicarbonate. Answer B. epoetin alpha. Rationale: kidneys produce erythropoietin. CKD causes anemia of chronic disease. Question 31. A client with SIADH is on fluid restriction. Sodium rises from 118 to 134 in 8 hours. Concern: A. cerebral edema, B. osmotic demyelination syndrome, C. seizures from hypernatremia, D. hyperkalemia. Answer B. osmotic demyelination syndrome. Rationale: rapid correction of hyponatremia risks central pontine myelinolysis. Question 32. A client with rhabdomyolysis has cola-colored urine. Priority intervention: A. restrict fluids, B. aggressive IV hydration, C. administer calcium, D. limit activity. Answer B. aggressive IV hydration. Rationale: myoglobin causes acute tubular necrosis. Fluids prevent renal injury.
Question 33. pH 7.36, PaCO2 50, HCO3 negative 28. Interpretation: A. fully compensated respiratory acidosis, B. metabolic alkalosis, C. partially compensated metabolic acidosis, D. mixed disorder. Answer: A. fully compensated respiratory acidosis. Rationale: normal pH with elevated CO2 and elevated HCO3 negative indicates full compensation. Question 34. A client with hyperkalemia receives calcium gluconate. What is its primary effect? A. removes potassium, B. shifts potassium intracellularly, C. stabilizes cardiac membrane, D. promotes renal excretion. Answer: C. stabilizes cardiac membrane. Rationale: calcium protects myocardium but does not lower potassium level. Question 35. A CKD client has metabolic acidosis and potassium 6.2. Which therapy addresses both? A. sodium bicarbonate, B. calcium gluconate, C. furosemide, D. insulin only. Answer: A. sodium bicarbonate. Rationale: bicarbonate corrects acidosis and shifts potassium into cells. Question 36. A client develops flank pain and hematuria. CT confirms renal calculi. Priority teaching: A. restrict fluids, B. increase fluid intake to 3 liters per day, C. high calcium diet, D. bed rest only. Answer: B. increase fluid intake to 3 liters per day. Rationale: hydration prevents stone formation and promotes passage. Question 37. A client with nephritic syndrome has RBC casts in urine. This indicates A. tubular necrosis, B. glomerular inflammation, C. bladder infection, D. renal calculi. Answer: B. glomerular inflammation. Rationale: RBC casts are classic for glomerulonephritis. Question 38. A client on peritoneal dialysis has cloudy effluent. First action: A. stop dialysis, B. send effluent for culture, C. increase dwell time, D. flush catheter. Answer: B. send effluent for culture. Rationale: cloudy fluid suggests peritonitis. Confirm and treat promptly. Question 39. Which electrolyte imbalance causes Schwastik sign? A. hyperkalemia, B. hypocalcemia,
C. Hypermagnesemia, D. Hyponatremia. Answer B. Hypocalcemia. Rationale: low calcium increases neuromuscular excitability. Question 40. A client with DI has urine output 600 milliliters per hour. Priority medication: A. Desmopressin, B. Furosemide, C. 3% saline, D. Spironolactone. Answer A. Desmopressin. Rationale: central DI is treated with ADH replacement. Question 41. A client with CKD is on ACE inhibitors and develops potassium 5.9. Next step: A. Continue medication, B. Hold ACE inhibitor, C. Add potassium supplement, D. Restrict sodium. Answer B. Hold ACE inhibitor. Rationale: ACE inhibitors increase potassium retention. Question 42. A client with metabolic alkalosis from vomiting has low potassium. Cause: A. Renal retention, B. Aldosterone activation, C. Decreased ADH, D. Insulin deficiency. Answer B. Aldosterone activation. Rationale: volume depletion activates RAAS, causing potassium wasting. Question 43. A dialysis client's AV fistula has no bruit. Priority: A. Apply warm compress, B. Notify provider immediately, C. Elevate arm, D. Apply BP cuff. Answer B. Notify provider immediately. Rationale: absent bruit indicates thrombosis, surgical emergency. Question 44. A client with hyperphosphatemia should avoid A. Apples, B. White rice, C. Dairy products, D. Chicken. Answer C. Dairy products. Rationale: dairy is high in phosphorus. Question 45. A client with acute tubular necrosis enters diuretic phase. Risk: A. Hyperkalemia, B. Fluid overload, C. Hypovolemia, D. Metabolic acidosis. Answer C. Hypovolemia. Rationale: large urine output leads to dehydration and electrolyte loss. Question 46. A client with CKD has pericardial friction rub. Likely cause: A. Hyperkalemia, B. Uremia, C. Hypocalcemia, D. Hyponatremia. Answer B. Uremia. Rationale: uremic toxins cause pericarditis in advanced renal failure. Question 47. A client with severe hyponatremia develops seizures. What must be avoided? A. Rapid sodium correction, B. Hypertonic saline, C. Airway protection, D. Seizure precautions. Answer A. Rapid sodium correction. Rationale: overcorrection leads to osmotic demyelination. Question 48. A client with metabolic acidosis from diarrhea has which finding? A. High bicarbonate, B. Low bicarbonate, C. High PaCO2, D. Elevated pH. Answer B. Low bicarbonate. Rationale: diarrhea causes bicarbonate loss, metabolic acidosis. Question 49. A client with hyperkalemia receives insulin and glucose. What must the nurse monitor? A. Hyperglycemia, B. Hypoglycemia, C. Hypernatremia, D. Hypocalcemia. Answer B. Hypoglycemia. Rationale: insulin lowers blood glucose rapidly. Question 50. A client with ESRD refuses dialysis and becomes increasingly lethargic with K 7.1 and widened QRS. Priority action: A. Administer IV calcium. B. Document refusal. C. Provide comfort measures. D. Encourage oral fluids. Answer: A. Administer IV calcium. Rationale: life-threatening hyperkalemia with ECG changes requires immediate cardiac membrane stabilization even before dialysis. If you survived all 50 questions, you are not average, you are preparing at a professional level. Renal and electrolyte disorders are where most candidates lose points because they panic with labs and priorities, but not you, not after this. If this video sharpened your thinking, make sure you subscribe to MCQs Master 101 because we don't teach fluff, we train clinical judgment. Drop your score in the comments, tell me which question almost trapped you, and remember, the NCLEX does not test memorization, it tests safe nursing decisions. I'll see you in the next critical care session.